This patient has a white cataract. I'm using Vision Blue to stain the anterior capsule, put dispersive viscoelastic, and then I'm going to check for intumescence, of which there is quite a bit. You can see all the liquefied cortex coming out of that 27 gauge needle. Make my main wound and then make a baby rexus intentional. I'm going to widen a little bit, and here now I'm going to use the IA to try and get rid of as much of that liquefied cortex as possible. Although I notice there's a lot in the periphery that the IA is unable to get a hold of. So I'm going to use this capsular ballottment technique I've described in another video, where you basically use the dull end of a chopper to push that peripheral cortex towards the center. That way, when you go back on IA, you'll be able to access it. And this basically gets rid of any entrapped cortex that may cause the Argentinian flag sign. I'm now going to extend the baby rexus here, and you can see there's no concerns about extension here. There's no Argentinian flag sign. And I'm going to extend it on the other side using the cystotome again for symmetry to enlarge the capsular rexus. And then I'm going to add dispersive viscoelastic. And now I'm going to sculpt down as deep as possible, and then here we basically break up the cataract into two pieces, and then I'm going to use mechanical fracturing forces, again just on position 1, to break up the heminucleus into two pieces. There's no vacuum, there's no ultrasound being used, and now I'm going to just sub-chop each quadrant and just using as much mechanical forces as possible on position 1, so I'm really not using much ultrasonic energy. Interestingly, the subnuclei closest to the chopper decided to come up, so I went after that piece. And again, keeping the phaco tip in the central safe zone, letting the chopper do most of the work. Now we've got two quadrants left, and here's one of them here being removed. Again, keeping that phaco tip in the central safe zone. As I'm down to the last two quadrants, I intentionally will begin to lower the vacuum on my phaco machine. And now I'm down to the last quadrant. Now, as I've told you in previous videos, and here you're going to see I'm going to basically sub-chop it just on with mechanical forces on position 1. So now I've got two basically sub-quadrants left. I'm going to remove one of them, and again, you want to just be very careful because that posterior capsule is very thin and very friable. And again, as I'm getting to smaller and smaller pieces, I'm intentionally lowering the vacuum on my phaco machine and just basically just nudging with mechanical fracturing forces. When I'm down to that last quadrant, I just felt like it was a little bit too loose, so I bring it up, I push it near the angle, and I add cohesive viscoelastic right there, and then I'm ready now to go ahead and put the IOL, and this is the scaffold technique, which I've showed in other videos as well. Here goes the IOL in the capsular bag, and now I can go back with the phaco tip with no concerns about the posterior capsule engaging the phaco tip, because the IOL is essentially acting like a backboard. You can see how well and stable things are once you got that IOL in there. Here I'm going to remove the viscoelastic. I'll then hydrate all the incisions, and that wraps up the management of a white intumescent cataract. I hope you found this to be useful, and thanks for watching.